Mon?
Oh, Punjazi.
Sikhona, but how are you?
I'm good. I'm good.
Hey.
We'll go in the next 4 minutes.
Yeah, no, there's still time. Yeah, that's fine. It is not as if this matters.
We'll go
I always have to change this.
4 minutes. Okay.
Otherwise, are you good?
No, I'm good. I'm good, sis.
Hey.
I just want to check something.
Okay, sure.
Otherwise, are you good? Oh, I'm good. I'm good. I just want to check something.
Actually, this life is going to be the new life now.
Yes.
I'm trying to change the new life. I usually am able to change this thing. I'm trying to put my name there. How do I do this one?
Whew. Okay, I'm gonna ask questions and I'll speak less.
Yeah, no, that's fine. And I'll tell you when I can't answer. When, if you ask me questions that I can't answer.
Yes.
Yeah, no, that's fine. I'm just trying to see. Why can't I change this thing? Come on. Why are you doing this to me?
We'll go in 5 seconds.
Oh, okay. Nobody must call me.
5 seconds.
here.
Right. Good evening, ladies and gentlemen who have joined us via various social media channels, Facebook, YouTube, and the Dr. Fundi website. Today, I've got a special guest, Professor Koleka Mlisana, Niye Mafwede, born and bred in Bazia, Umtata, in the Eastern Cape. Today, she is my special guest. Professor Mlisana, welcome to the Dr. Fundi platform, but I still need to introduce more of your credentials, but just to welcome you first.
Thank you very much. Thanks, Dr. Fundi. Yeah, it's a pleasure for me, and I appreciate you inviting me to your famous platform. Thank you.
All right, thank you very much. But for my viewers, welcome. Let me tell you a little bit about Professor Mlisana. She is a qualified specialist in microbiology. She has a PhD in microbiology. In her study, she focused on sexually transmitted infections and the subtype C HIV, which is the subtype of HIV that we find in the larger part of Southern Africa. So she's got an MMed in microbiology from UKZN. She's got an MPhD qualification before then from KZN, and the PhD also from KZN. So she really represents my alma mater. All right, and her current job responsibility is that of an executive manager, academic affairs, research, and quality at the National Health Laboratory Service. Before then, she was an associate professor and the head of microbiology at the Department of UKZN, working also with NHSLS, based at the Inkosi Albert Lutuli Central Hospital in Durban. The reason for me inviting her today is that she's one of the people who is in the thick of things when we are talking this COVID-19 response by South Africa. She is a member of the Ministerial Advisory Committee of the National Department of Health. She's actually the chair of the Laboratory Testing Committee. So all matters that have to do with testing for COVID-19 in South Africa, there is no person beyond her. She is the one who must give all the answers about whatever good or not so good things that are happening in that area. So I'm glad to have her today because I think by the end of this interview, we will have learned a lot about her as a person. We'll have learned a lot about National Health Laboratory Service, the employer, but also a little bit about the profession of microbiologists, because the purpose of being here is also just to inspire the young up-and-coming people so that they can say, I also want to be like a Professor Mlisana. So my first question then, just to get things going.
Okay.
What attracted you, Prof. Mlisana, to actually choose microbiology as a specialty? And in fact, for people who don't know anything about microbiology, what is microbiology?
Yeah, that's probably a good question and a good point to start. And I'll probably give you a short, story about my children and their attitude towards me. So microbiology basically is really a study of microbes. Microbes are microorganisms, basically, whether it's viruses, bacteria, fungi, all microorganisms. So within medicine then, as a microbiologist, your role gets to be to actually understand the cause of the disease. So my favorite is when somebody asks me, so what do you actually do? And I always say, I actually am the brain behind your doctor. Honestly, and they say why? Because I mean, you walk in, somebody will walk into your rooms, Fundile, and they'll say, okay, fine, I've got and you think, oh, you probably have got a urinary tract infection. And what
Yeah.
do? You take a urine sample.
Yes.
And you say, okay, fine, come back to me, I'll give you results, and then you send that sample to me. And what I do in the lab is to actually then look at that sample to actually see what causes the infection. So we're actually able to tell you. And so, within a day or two, depending on the turnaround time, which we'll probably touch on later,
Yeah.
then I can tell you, patient X has got an E. coli, which is a bacterial, a bacteria that commonly causes urinary tract infections. And I don't just give you the cause, I also tell you what to treat that patient with. Because once we identify the organism, we then test it against different antibiotics. And I'll say, okay, fine, don't use amoxil, don't use cotrimoxazole because it's resistant, but
Yeah.
use ciprofloxacin. And what do? You call your patient back and say, oh, you know what, Mr. So-and-so, you've got a urinary tract infection and I'm going to give you ciprofloxacin. Who told you that? I did. So that's basically. So I think, just for people to know, we work behind the scenes. We give the doctors the diagnosis and also obviously, I mean, we're always involved in patient management with advising which antibiotics to use, how to use those antibiotics, when to stop, and also even with infection and, prevention and control. When we're talking about IPC, there are usually microbiologists behind. So that's basically what microbiology is.
Yeah.
And then the story about my children. So my husband is a pediatrician, as you know.
Yeah.
And obviously, I mean, he, earlier in our lives, he would go to work with his stethoscope, and I go to work, just like me. And they would ask, Mama, are you a real doctor? I'm like, what do you mean? Am I a real? Why don't you use your stethoscope? Because they couldn't understand. What is actually, I guess it just shows that there are wider fields. There are lots of other different fields within medicine, and people just have to get exposure. And yeah.
So working behind the scenes, it's okay for you. You don't miss the actual direct contact with the patient.
Actually, I don't, and I usually say to my friends, please don't make a mistake and have a heart attack in my presence thinking I will help you.
Yeah.
Because, I mean, speaking, I haven't really examined a patient since what? Probably 1988. When was that? Because that's
That was the year before I qualified.
Yeah. So, and I actually don't miss clinical medicine at all. I really don't. And I think, and I usually say this, for anybody who wants to specialize within pathology, the first thing you need to settle within yourself, whether you are going to be fine without doing clinical medicine. Because really, as a pathologist, even though you still do, as a microbiologist, we can do rounds, but it's only just rounds. It's not you are not directly looking after patients, but you're advising the clinicians. And sometimes hematology, you get clinical hematologists, but the bulk of pathology really is not clinical at all. So people must just be clear that I'll be fine without seeing patients. Yeah. And for me, I usually say, if I leave my bags in the incubator, I find them there.
Yeah.
And they'll do whatever I want, unlike patients and their complaints. And yeah.
So do you still have a stethoscope?
I don't actually. I don't. No, I do not. Really, I haven't used a stethoscope like in so many years, but I don't miss it. I really don't.
All right. Now, Doc, if one looks at your career, you've been an academic for all of these years. You've been working closely with universities, producing new doctors, producing new specialists. Have you always wanted to be an academic?
No, actually, no. I think I am one of those people who, for me, I always say I really have just been amazed at how, as you know, I'm Christian, how God has actually directed my life. In that I have seen doors open, doors which I never thought would open. And, I find an opportunity gets presented to me and I step into it. Because even the specializing in microbiology, people often ask, had you always, did you excel in microbiology as a student? No, I did not. Did you ever love micro? Not particularly. But for me, it really was, at that time, we had we had been married for a few years and we had young children. And it really was more around family circumstances, because I was looking for a job where at least I could be home and know that I am finished. Unlike, as a doctor, you come home, somebody's going to call you, you are never really truly off. And so, and my husband was actually doing pediatrics then. And then, there was an opportunity in micro. They had, there were 4 registrars who had been trained, who had just qualified. And so there was a vacancy. And I walked in and I was like, oh my goodness. But it's amazing. I developed love for this subject, as I was training. And And from there, actually, I was not always in academia, because after micro, I had actually a good stint in the private sector.
Oh, I didn't know that.
Yes. I actually worked with one of the labs in Durban for a full 7 years. That's when the kids were growing up.
Oh.
Yeah, but then how I got back, even that as well, there was an opportunity when Professor Abdul Karim, actually, when Caprisa was starting. So he came to me and said, would you consider coming into research? And then, as a doctor, I didn't really know much about research. But I was like, why not? Let's try it and let's see. And I was actually with Caprisa for almost 10 years.
So now you have switched from being an academic. You are now you are a corporate person, an executive manager at the National Health Laboratory Service, at the head office. Is it still now? So that switch from being an academic in a academic environment to being an executive manager within a corporate environment. Yes, I'm sure there's still a need for training and development of people there, but is there a difference in terms of the new role that you have?
Actually, obviously there is a difference to an extent, but for me, when I was at UKZN, as you have already said, I was the head of medical micro. But then the position I'm at, at the NHLS now, I'm actually overseeing academic affairs. And research, which actually means I then look after academic pathology at national level. So for me, I thought it was a great opportunity in that one could actually make an impact, because then I have to see to it that the training of pathologists happens. There's research within pathology, and so I interact a lot with all the medical universities. So it really is just a bigger responsibility and a broader platform, but still ensuring that research happens, and in academia. And I think now there's also an added arm of ensuring quality assurance within laboratories. So it's still, for me, even though it's actually corporate, but there's a lot of academia that I still interact with.
And with a national focus this time, rather than a regional, focus.
Which for me, actually is a lot more. It therefore actually gives one an opportunity to impact the training in the country, which is what I enjoy. This one feels I can make a contribution.
All right. So, beginning of 2020. COVID-19 happened in Wuhan. We were all crossing fingers that this thing mustn't come this side, but it spread so quickly. By the end of January, it had already been declared a public health emergency, of international concern. What was going through your head at that time?
I guess at that time, I mean, as you say, we all were wishing that, hey, let's hope it's not going to get here. But at the same time, we knew that it's just going to be a matter of time. And I must say, I often wonder if we could not have equipped ourselves better if we had, taken action then. But also, hindsight is always the best, when you look back and analyze and Yeah.
Yeah.
But I think, you know, we quickly became aware that it was just a matter of time.
Yes,
And
yes.
and so when it hit our shores,
On the
you know, when
on the 5th of March.
yes, you know, when a new, you know, epidemic and new infections come in, and something that you all don't know, so it's a matter of trying to grapple with whatever you know information or data was coming out of you know the other countries,
Yeah.
and also at the same time, getting an understanding of how then are we going to deal with this as a country.
Yes.
And I mean, I remember now from the lab perspective, because it was an outbreak. So obviously, you know, when we had the few cases, it was mainly handled by the National Institute for Communicable Diseases, NICD.
NICD, yeah.
Because they actually handle outbreaks. And so as a result, you people would have noticed that when COVID-19 testing started, it was actually mainly from the public perspective, it was at NICD.
Yes.
And yet then for the private sector, that's why then, in fact, originally the numbers, there were more in the private sector.
I'm gonna get there.
Yeah.
I'm
Yeah.
gonna get to that one. Yes.
Yeah.
So
Yeah.
you then got to be invited to be in the Ministerial Advisory Committee
Yeah.
to be part of assisting the country to deal with this pandemic. And you were not only just invited to be in there, you were also made the chair of the lab testing committee. What does that mean? What did it mean to you?
Yeah. Well, firstly, how this all happened. So you know, there's a meeting that the the minister had actually invited a number of us, where he was basically just saying, you know, we've got this epidemic in our hands, and you know, what is it that needs to be done? And then he said he thinks there needs to be an advisory committee. He will actually send invites, and you know, with different groups, because, and actually it made sense because there was a significant focus on diagnosis. So the laboratory pathology group was definitely, you know, critical, and then the clinical response to that, which is why then there's a clinical group as well. But obviously, as an epidemic, it becomes a public health issue. So that's why there's also a public health group. But I think what also was great was when then he also decided that there should be a research, you know, a group as well, because obviously whilst we're trying to ensure testing clinically is managed well, we also don't want to leave out the research aspect. So then the next thing that happened was that, you know, we got invited. And so we were then, obviously, because I'm a pathologist, so a group of us who are in the laboratory pathology space, in the lab pathology group, and we then were supposed to elect a chair. So basically, it was just the group, you know. The minute
so your colleagues,
exactly,
colleague, you must be the one.
Exactly. And I was like, guys, really? I mean, before I knew it, there were like 4 or 5 people supporting. Yes, colleague, I should be. I was like, okay, fine, you know. But also, I mean, go back to your question, what did that mean? I think for me, such instances are always humbling, because I mean, a lot of times you don't really know how people view you. You just go about and you're doing your work and you try to do your best. But when then you see recognition, not as if we have to live by recognition, but when your colleagues actually show that recognition, I think for me, it always is humbling, you know, and it's like, oh, wow, you know, thank you guys, you know, but I don't want, I'm not taking this lightly, but, you know, but also it's a good thing. I mean, it also is affirmation in that well, you must be doing something right. So keep it up. Yeah.
You see that humility that in Bazia was instilled in you, you know, even when you are being lifted up by your colleagues, you still think, you know, guys, take it easy.
I know, yeah.
All right, but anyway, and so what is your responsibility then as the chair of that lab testing committee, of the advisory committee?
Yeah, one thing that has really been very clear from the minister is that he has set us, the big group, there's about 51 of us.
Yeah.
The whole mandate is for us to advise the minister and the Department of Health. And I mean, we keep harping on this. Now, when you advise somebody, you advise and you
Yes.
leave it to that individual to take the advice or not to take the advice. And I
I
think
was about to ask that question because, you know, as an advisor, you advise, you recommend, but
Exactly.
it is
And that's
up to the official to whether to take your advice or not.
Exactly. And you can't take the person to task if they don't take your advice. You know, all you do is you put the facts on the, on the table and you say, in our opinion, this is what the data, this is what science is saying. So our recommendation is this, and you leave it, to that individual.
You don't
And
feel
that
so
is-
if your advice has not been taken.
No, I mean, it should be big people, be a big girl and accept it and move on.
Yeah.
It means this one, he doesn't, and it's okay to differ. And it's okay for somebody not to take your advice. And it doesn't mean now you must throw your toys, out of the court.
Yeah,
But,
yeah.
you just move on. Yeah.
Yes, but
basically-
but also, I mean, there are other people. It's not only your group that is advising. There are other groups, economic groups, and whatever other groups. And so, at the end, a decision that must be taken must be after considering all of those.
Everything. Exactly.
Yes.
Yeah. So I mean, there's a balance. We're not we are not the ones that are calling the shots. We
Okay.
put our facts on the table, and then I'm sure the minister looks at various other aspects and then comes up to the decision. I mean, make a decision.
But largely, most of what you guys advised or recommended has been carried through.
Actually, all of, really, I can't even think, of a single one that has not really gone through. And I mean, the minister has been very upfront. He actually comes and we have meetings with him. We take him through. So what usually happens, a lot of times he will actually ask for an advice.
Yes.
And, this is how it started, in the beginning, where he would actually ask for an advice. And us, we're like, sometimes we actually do want to recommend certain things, even without you necessarily asking. Can we do that? And actually, we now have been allowed in that we will also raise topics that we think need to be dealt with, there should be some guide, on that. And the majority, I mean, really more than 90% of what we have advised has really been accepted by the minister.
Yes.
Yeah.
All right. So now, if we look at South Africa,
Right.
at that time when we had just got our first patient, what was the capacity of South Africa to actually be able to test people?
Okay. So firstly, for us to actually determine the capacity, obviously, is to understand what the testing is. What were the testing, how were we going to test the,
Okay.
for
Maybe
COVID?
let's start there. Yes, let's start there. The testing of somebody to confirm that this person has got COVID-19.
Okay, so if you're looking at diagnostics, so this is a viral infection. Take a sample from an individual, and what we do with that sample, there are two things. You can, in any diagnostics, actually, irrespective of what infection it is, you can either look for the organism, so look for the virus, or you can look for the for the body response. So it is either the virus itself. Now, when you're looking for the virus itself, you either look for the genetic material or you look for an antigen, which also, is actually part of the virus. So it's either that, or if you're looking for the body's response, that's when we then talk about antibodies, and that is serology. So when it comes to COVID-19, currently, the only method of diagnosis, if you want to know whether somebody has got COVID-19 or not, what you need to look for is actually the genetic material of the virus, which is tested using PCR, polymerase chain reaction. So that's what we're using at the moment. And I mean, that's what is being used globally. Antigen detection tests, we don't have those as yet. Antibody or serology tests in the country, we haven't got a test that has actually been approved by by SAPRA. So We don't have that as yet. So for
Yes.
now, when we're talking diagnosis of, of SARS-CoV-2, we basically were talking PCR detection.
Yes.
Now, when we talk PCR detection in the lab, there are, because it's a specialized kind of testing, it's a molecular testing.
Yes.
It is not the kind of test that gets done by any lab. As a
Yes.
result, the labs that do molecular testing are usually the academic labs. So it's the big central labs. So if you're looking at all the, the 9 medical schools, those virology labs would do testing.
Yes.
But the advantage that we have as well in the country is that we have got this huge program of HIV as well as TB.
Yes.
Because everybody knows when we talk about HIV, we always do viral loads. Now, viral load testing is actually a PCR test.
Yes.
The machines that we are using for viral load for HIV can then be used for PCR for COVID-19.
COVID as well.
And then the third is the fact, now for TB diagnosis, everybody knows now that, TB diagnostics was changed significantly when we had Gene Experts
Gene Experts, yes.
platform becoming available. So there also are actually cartridges that can be used for COVID-19. So when we talk capacity then in the country, now there are platforms that actually do PCR, which any research lab will have. And we often say those are the open platforms, and you would find these in academic or research labs. So when we're talking capacity, we then had to look who in the labs actually are currently doing PCR testing of any other kind, because that means we then could use those platforms. That was one. And then the second one was, where are our viral load testing platforms?
Yes.
And are we using those fully? Is there like 100% usage for viral loads? And the answer was no, it's not full capacity. So what we then looked at, what is the residual capacity? Don't disturb HIV viral load testing, but then what's the capacity that is not used, because we then can utilize that for COVID-19. And then we had to look at the same for Gene Expert. Are we utilizing Gene Expert 100% for TB? And the answer is no. So the residual capacity then became available for COVID-19. So that was what we really had to look at.
Yes. Okay.
Yeah, as NHLS now.
Yes. All right. And then the private labs,
Yes.
they have their own investment in their own testing capacity as well.
Yes, that's correct. Yeah.
Yes.
So you find that even for the pathology, the private pathology labs, they do viral loads, they do Gene Expert, they also have got open platforms for PCR anyway. And so we then had to look at that capacity as well, for the private sector. Yeah.
Because when you're looking at the country's capacity, it must be the combined capacity of both public and private.
And private, yes. So we did that. And and that's when all these big numbers were we were flying around, and actually that is the true capacity, because basically what we were saying was that with now the open platforms in the NHLS, plus the viral load residual capacity, as well as Gene Expert residual capacity, if we were to run labs 24 hours, we will be able to do 35,000 a day over, in 24 hours, because we're looking at that. And on the other side, the private sector as well, they were saying, with what we have, we can easily go 15,000 a day.
Yes.
So when you combine that, so we're looking at about 50,000 a day.
Yeah.
So that was the available capacity.
Yes.
But now, what really has been also a challenge is that we're talking of a global pandemic.
Yes.
Now, when I talk about viral load platforms, I'm talking about platforms that are used globally.
Yes.
When we talk Gene Expert, it is used globally.
Yes.
The same, are the other, open PCR platforms.
Yes.
And now when we talk about PCR, how we actually do the testing is that you take your sample. Now the virus that is causing, COVID is an RNA virus.
Yes, it is.
So you've got to extract the RNA from the sample.
Yes.
Once you've extracted the RNA, you then amplify it in the PCR. Okay?
Yes.
So when we're talking about doing the test, it means there's an extraction stage and then there's an amplification stage.
Yes.
Now, for the open platforms, you've got to do both stages. So
Yes.
you need extraction kits.
Yes.
Once you've done an extraction, you need amplification kits, and then you get your results.
Yeah.
As opposed to the high throughput platforms, which are the viral load, and for instance, the Gene Expert, we've got huge machines that actually can use the Gene Expert cartridges.
Yeah.
Those ones are actually fully automated.
Yes.
In that you just need the reagents for the machine, you put your sample in there, you let it run, it will extract and it will, it will amplify, in a closed system, and you'll get your results.
Yes.
So when then we had this estimated capacity, the biggest challenge that we faced was when we realized that the orders we were placing for the extraction kits or for the big, platforms, the high throughput platforms, they were just not coming in. I mean, take Gene Expert, for instance. I mean, Gene Expert is actually, we get it from the US.
Yes.
And when we actually would have wanted like 50,000 or 100,000, expert kits for a week, we only get 10 or 20,000 kits.
Yeah.
And I mean, to actually do 20,000 tests a week when we had said actually we want to do 30,000 a day, that's not going to work. And the same thing with the others. I mean, the Roche and whether it's Roche or Abbott, we were just not getting what we're placing on order, and that really has been a huge challenge.
So that then has created a situation where the numbers are increasing that need to be tested, but the ability to test them on time and issue the results is actually hampered by the unavailability or low availability of the kits.
Yes. And in fact, so we had that. And then, you remember in the course of the pandemic, there was then the move to community screening and testing.
Yes.
Now, when community screening and testing was initiated, the idea there, it was very clear that, remember I guess nobody can ever forget this, the famous, announcements that we made, and Slim was talking about, we've got to find the flames, the small flames, so we can, prevent the big fires. And what does that mean? We need to go out there, test as many people as we can to identify where the infections are. And so when we went out to do that, there was actually a very clear guide, which actually said, you get into the community workers, get into somebody's home, screen them for symptoms.
Yes.
Those that have symptoms, refer them for testing.
Yes.
Now, not everybody did that. That what ended up happening, it was like, now people were not really looking for symptoms. They would walk into
a home. Looking to take samples.
Yes. So people just walked in, took samples. So, and we're saying this why? Because you would find, on the day, samples that are coming, like 1,000 samples, come in, you test them, there's only one that's positive.
Yeah.
Now, that is really not then helping us, because we are now utilizing these difficult to find kits, these huge numbers, to get very, very few infections.
Yeah.
And I mean, you could see this, there was such a glaring differences in the provinces, in that there were provinces that were testing thousands, but the positivity positivity rates were very, very low. Whereas there were other provinces where they were doing which was like targeted testing, where, I mean, you could
Like
say
Western
that
Cape.
these must have been people with symptoms because the positivity rates are higher. And that's
Yeah.
what we wanted to do. So that's why then the system just really, got bottlenecked, and we hit a crisis, and we just
Yes.
couldn't handle the numbers.
So has there been a toning down on the community testing? Because in the initial idea, it made sense. You were supposed to only pick up samples from those who've got the symptoms and not just anybody.
Yeah.
But then has there been any correction of that?
Yeah, we're actually in the process of doing that now, because I think everybody now else realizes that, this is where we are. And as a result, we've had these backlogs in the lab. And so we are now trying to say, no, let's go back to targeted testing.
Yes.
And so right now we're saying really that we should only be testing people who are symptomatic. And in fact, even, apart from that, we're prioritizing testing now, because we're realizing that, I mean, we're not going to get better. We're not going to get more kids. And I know government, everybody is really trying their best to see if we can get a lot more kids coming in. But whilst we don't have that, now we've got to sit and say, what is critical when it comes to COVID management? And really, so for us, we are saying patients who are in hospital, for clinical management, those are definite priorities. So in the hospital, testing must be prioritized. The second critical priority becomes healthcare workers. We will not sustain a healthcare system without healthy healthcare workers. So the healthcare workers are priority number 2. And then comes the contact tracing, symptomatic, So if somebody from a home is tested positive, then we send the team out. Contact tracing, especially those with symptoms, those must be tested. And then close contacts, they would need to be tested.
Yeah.
Otherwise, really, apart from that, somebody who actually presents with symptoms, then but I mean, obviously it's prioritized. So when samples come into the lab, so what we are now in the process of doing, in actually putting stickers, we've got red stickers for this, for hospital patients, red stickers for healthcare workers, orange stickers for contact tracing, all of that. And it's actually, we're currently introducing that. And whether it has been taken up across the country, it's going to be a matter of a few days or a week or so.
So this morning, I'm a resident doctor in one of the radio stations here in Johannesburg, 702.
Yes.
So my topic today was around medical ethics in the context of COVID-19.
Okay.
And one of the questions that they asked me was, in the Western Cape, they've also introduced that if you are under 55, they will not be testing you over and above what you've just mentioned.
Yeah.
And so one was then trying to see, from a medical ethics point of view, is it something, obviously we understand that there's this thing called rationing, where the resources are not enough. There has to be rationing. But is it something that is ethical? I just want to hear your view.
Okay. Yeah, no, sure. Remember now, actually, I mean, we've tested more than 1 million people right now.
Yes.
And if you're looking at, the positives that we've got, I think we're close to 40,000. We're more than 50,000, actually, I think about 60 or so.
Yes.
So, which is a lot, that's a big data set. So we therefore are able to draw, certain conclusions from what we are seeing. So what the Western Cape has done, they've looked at the data across the country to look to see who are really at risk. And that's where the cutoff of 55, comes from. In that really is beyond 55, like of us, that's where comorbidities, are higher, and the other complications, are a lot higher. And that's why then, as you say, for rationing, they had to come to a point and say, what cutoff are we going to use? But remember that if you are under 55, if you have symptoms, and you've got comorbidities, you will be tested.
Okay, so if you are still high risk, people of
Yes,
comorbidities,
yeah, you will
still
still
be
so,
taken care
yeah,
of.
you still be tested. So you are not completely, cut off. But I really think it's actually a good and a decisive decision, which we really do need. But people need to understand right now, there is community transmission everywhere.
Yes.
And the question that we need to start asking ourselves, is it going to be necessary to test everybody? Probably it's not. This is a flu-like illness.
Yeah.
We don't go testing for flu, whether
Yeah.
you've got flu or not. If you've got flu, you take treatment, to treat the symptoms.
Yeah.
And so we're moving towards that, where we are saying it's only when it is necessary to make the diagnosis. But
Yeah.
otherwise, if you think you have been exposed, but you have got no symptoms, we know how to manage you. Self-quarantine.
Yeah.
Or self-quarantine for 14 days, because it's a flu-like illness. After
Yeah.
14 days, it will resolve. So there really is no testing.
Assuming that you are not one of the high-risk people who will
Exactly.
then end up in the
What we
hospital.
call the comorbidities, yes.
Yes, yes.
So
Okay.
really, I don't think there's an ethical, there are any ethical issues there.
No, I just wanted to hear. Look, in the reading that I did around that, it was actually part of the values, behind medical ethics, where there's a point where you have to ration, and there are certain things you need to look at in there, and the issues of age, comorbidities, the life years ahead, and maximizing post that intervention. So they actually have, a solid case to actually ration.
And I mean, as I say, the best is that there's data actually. So we actually have got data that we have seen. So it's not just sucking, their thumbs at all.
All right. Now let's then say Western Cape has got 65% of the load so far, but our home province, the Eastern Cape, is coming very, very fast. They are number 3 in terms of the total cases, competing with GP, but they are number 2 in terms of the deaths. And when one looks at the hotspots, the Nelson Mandela Bay, Buffalo City Municipality, OR Tambo, and Krizani are actually increasing quickly. So how is NHLS, doing in terms of capacity to be ready to deal with the rising numbers there? Because you already have a bit of experience from Western Cape.
Yeah. Okay. Specifically, insofar as testing is concerned, in fact, because we all know, and we keep saying this, that we're still going to see more numbers. So there's going to be an even higher need for testing. So what we added to what NHLS has as capacity in the private sector is that the academic research units have come on board as well. So all the medical schools that have got capacity to do PCR, we actually, have been looking at them, going through, what facilities do they have, what are the human resources that they have, and then look at issues of quality. And once we feel this lab can actually do testing, we then look at their connectivity. How are we going to link them to our NHLS, information system for results? And for samples and for results. So we are busy doing that. And so, for instance, in the Western Cape, UCT, there are quite a number of research labs that should be starting now to test, and even at Tygerberg. And the same thing we want to explore, we're exploring in Walter Sisulu. Because then we had to say we're saying what facilities are there. We're doing the same in KZN everywhere, actually, across the platform.
So those provinces that happen to have, medical schools. I'm saying you're doing the same for those provinces that have got medical schools.
Yeah, we're doing the same. Yes, we're doing the same across. And in fact, even over and above that, we have opened this and said anybody else who has got the capacity, they must come to us. We've got a tool. There's like a process that they have to go through. So that's one, to increase testing. And the other big thing that actually NHS has done is that we have diversified the platforms of testing.
Yes.
In that, yes, we've got the standing viral loads and gene expert machines, but then on the open platforms, we've actually gone to look out for extra, for more. And we're also exploring, the bottleneck of extraction. The
Yes.
problem with extraction, whether it's RNA or DNA, is that most of the systems are manual or they are semi-automated. So we're now looking for automated platforms, because if then we can have automated platforms in Mthatha, in PE, in East London, where the testing is happening in the Eastern Cape, then the productivity is going to definitely increase. So we are in that process. I mean, there are lots of new instruments that have been placed across the country. Right now, the focus is still in the Western Cape, but we're also building capacity in the Eastern Cape.
Yes.
Yeah.
All right. No, then that makes a lot of sense. Was at least I was starting to worry to say, with only 2 provinces, okay, 3 provinces where there's high numbers, what will happen when we have more of the provinces? Will we choke further, or is there a plan to upscale? So at least I hear that there is a plan.
Well, yeah, we really are trying our best. I'll be the first one to say there's nothing that's tight, that's ever going to be tight and fully proven. But, it's going to be a matter of, we just have got to ask ourselves, are we doing the best that we can? And I think right now we're at that stage. And in fact, even, with the bottleneck of the extractions, people have come up with innovative methods where we're using heat inactivation, which actually allows us to go ahead and amplify without having to use the extraction kits.
Is it the UCT that came up with that?
Sorry?
The UCT who came up with that?
UCT, yes. That was a protest scale. And right now, I mean, it's being used in PE. They're very happy with it. In fact, PE, they were able to clear their backlog using heat inactivation. And now they are assisting East London. And in Mthatha, they just also started, there's also the pooling strategy where they, especially for the community screening and testing, because there we expect the positivity rates to be low. So Mthatha has been doing that, and they really are trying to come up so they can clear whatever backlog that there is. So there's a few innovations here and then. Then all the academic units, I mean, even CSIR now is testing, the Agricultural Research Council has also come on board. So there are various, entities that really have come on board. And the mines as well.
Yeah. So about 2 Fridays ago, I interviewed Mr. Jonathan Brumbeck from the Solidarity Fund. Because I wanted to understand the health response. What are the things that they are funding, from Solidarity Fund? Then he mentioned something about Solidarity Fund having assisted NHLS. I just wanted to hear about that, to capacitate in one way or the other.
Okay, so I know that there was actually funding that we got as NHLS now towards testing, which was specifically for NHLS, but also over and above that, when the academic research units came to us as NHLS, now they sort of formed a consortium, and they said, here we are as academic researchers, we've got the capacity, we want to therefore support you. So what we want to do is that whenever there's overflow, we want to be available. But what we're going to do is we will request and apply for funding from the Solidarity Fund so that whatever expenses we incur, you don't have to bear as NHLS, but we then will get funding from Solidarity Fund. And then, so what then happened was that it was the Academic Research Consortium, NHLS, and then the MRC as the funding body. So the MRC then submitted an application to the Solidarity Fund, and fortunately, they actually were granted that funding. So we are now, so when I talk about academic research labs, that's how they will be funded. So we really want to make sure that every medical school that has got capacity for testing, they can actually tap into that. And we're busy trying to equip everybody to be able to.
So looking forward, you more positive. Once all of these things come on stream, your CSIR and everyone else, you will feel a little bit better than you felt 2 weeks ago.
I think for me, once I can be confident that we are able to test all samples that are coming within at least 48 to 24 hours,
Yeah,
then I will have a peaceful night's sleep.
yeah,
Because now, because we're still trying to catch up with some of the old samples, I just feel we're not there as yet. We really
Yeah.
need to be at a point where I want to get the confidence that at least, we more than 60, 70%, 24 hours turnaround time, then, I will know that we really are close to it. So until we get to that, I am not going to be, at rest.
yes. But the Premier Winde from the Western Cape, it was reported in the news today. He was really complimentary to NHLS in
Yeah.
terms of massively reducing the backlog from something like 20, 30,000 to something around 3,000 at the moment, and with projections that within the next few days, actually, you guys will be current. So that must be something, a good feedback for you guys, especially because that's like 65% of the load of the country.
That's actually true. Well, thank you for that. I must say, actually, I haven't looked at it that way, but it's actually true. Because, the Western Cape, they really have worked hard and they really have done a great job. Like you say, we've managed to reduce the backlog now to about 3,000. If you're talking 3,000, then that's like a day's work or so.
Yeah.
So I'm really thinking it's just a matter of days, and the Western Cape will be, at my 24-hour, turnaround time.
Yeah.
But it's just one province out of so many, and
Yeah.
so the next focus then has got to be the Eastern Cape.
It should be the other 2 coastal provinces, because the 3 of them plus Gauteng, they make up 97% of the load of the country. So if you concentrate on those 4, then you have very little work in the other provinces.
No, definitely. Because for instance, in the Free State, there are no backlogs at all. The testing, their testing is up to date. But really, like you're correct in saying now, we just have got to focus on these 3 major, provinces. But it's work in progress. And like I say, we're really trying, and I think the labs are really trying very hard, and they're really working hard. So it's just to go through this, and then we see, whether we're able to sustain then shorter turnaround times.
Now, your staff, how safe are your staff who are handling all these samples? And when I say your staff, maybe let me not just put it on NHLS, the labs in general. Have you guys seen any spike in them getting infected in the course of doing their work, or they are well protected and they follow the right protocols, and you haven't really had cases coming through?
I must say, thank God, we have had a few infections, and when you look at the infections, in fact, most of them, if not all, they really have been from community transmission and not within the lab. In fact, we've had quite a few in Grooterschuur. And when we sort of then analyzed to see who was getting infected, none of them were from the testing labs.
Yes.
So, which means, it would either be in, hematology or any other lab. And so, which means they would be getting it from the communities. But as far as now ensuring, protection of the staff, that one thing that we cannot compromise on is PPE, obviously, so in fact, everybody who walks into any NHLS building, your temperature gets taken. You must have a mask on, and when you come in, and remember, for the laboratories, we're working in safety, in biosafety cabinets. Yes. So you can't really perform any testing outside of that of those safety cabinets. So the BSL-3s, BSL-2s are actually followed strictly, and there's actually also every week, I think, we actually do a health assessment. So where there's screening, you've got to write down, what symptoms you have if you don't have any, and if you have any symptoms, you then go and see a nurse, and then you would go for testing. So we really have tried to make sure that we put all the measures that need to be put in place for our staff, and obviously, the social distancing. In fact, some of the labs now had to change their cycles of work so as to accommodate fewer numbers, but then with just more shifts, so as to make sure that there's enough social distancing. So we really have tried, but I mean, obviously, we do get a few infections, like we are part of the, of the community. And there may, actually, I think there's 1 or 2 people who passed on, in our condolences to the families.
Yes. All right. So looking back with that benefit of hindsight wisdom, what could you have done differently if you had to start planning in January?
I think what we could have done differently would have been to assess our capacity much earlier, and also to do a much earlier lead on securing testing kits.
Yes.
As well as automating our platforms earlier.
Yes.
Really, I think if we had done that, if we had actually automated the platforms much earlier, so that by the time, we had our first infection in March, by April, we would be getting the instruments coming in, I think we would have done a lot better. And also, if they had, well, I guess, we could not really change the access to the reagents.
Yeah.
Now, maybe one could then say, if we had internal and local production, that would have been great. But we don't have that. It's only now that we're encouraging people to explore, local products.
Yes.
Yeah.
Because I understand that some of the countries out there, in a way, put pressure on some of their companies to put their countries first before they look at exporting to countries like South Africa.
Exactly. Yes, exactly. So and that is where then local, production would have actually come in. But like we say, we are now wiser.
Yeah.
And also, right. And also I think now for the country, maybe if we had managed the community screening and testing better, and actually targeted those that who had symptoms, would not have gotten to where we are.
Yeah, a flood of tests, from people who are not necessarily at, high risk.
Yes, exactly. Yeah. Right.
But you've done great work, you and your team. But I just want to find out from you, what are the 2 or 3 things that make you, feel it's been worth it? The good things that so far, yes, challenges are still there, but there must also be good things. You've tested, as at yesterday, you had tested about, as a country now in total, 1,060,000.
Yes.
1,060,000. And you've moved from testing about 121 in a week to about 32,000, in a week. So that's a lot of capacity.
Exactly.
That's a lot of outputs, not capacity. So there's definitely been a lot of ramp up. You've been, almost doubling every week or 2.
Every week. Yeah.
So
in fact, you say what are 1 or 2 things? One of the things that actually really put a smile on my face is that we submit these daily reports to the incident management team within the Department of Health, and these are daily. So we will actually submit a report and say so much has been tested in the last 24 hours, now including both public and the private sector. And I always smile when I see that, oh, wow, like this morning I was actually submitting the report and I was able to say, almost 20,000 tests were done in the public sector in the last 24 hours. Because,
that's beautiful.
because yesterday we did 19,934. So I mean, it's like, that's close to 20,000 in one day. And so that is great.
And when one looks at the total numbers tested to date, already 52% of 51.7 is actually from the public sector, and 48.3 is from the private sector. And in the first month or 6 weeks, the public sector was lagging behind in terms of testing, and the private sector was ahead. So to be at a point where you guys are actually testing the majority, I mean, that's reason to actually say there's been improvement.
No, definitely there is. There has been a lot of improvement. And I think now, you were just making the example of what the Western Cape has done. When we've been through a very difficult time, and we're seeing the labs coming out of that and, getting, back on track. And so that really is a great improvement, and is to really appreciate the hard work that people are putting into testing. So, few things, there are a few good things. Obviously, we're far from being there, but there's significant progress that is being made.
Yes. All right. What parting message, encouraging message do you have for fellow South Africans in terms of the work that you guys are doing as part of the whole? You're part of a team. Yeah.
First thing, people have got to try and not be so scared.
Yeah.
Really, there's a lot of fear around COVID. We must not forget it is a viral infection. It is self-limiting. It is really not, the mortality is not as high as other viruses. And I think
Ebola, for example.
Yeah, it's like Ebola. It is not really. And so we really need to get out of this fear as a country. One thing is that...
But the numbers of deaths are scary. People are, we're starting to hear relatives and people, passing away. So people are starting to think, oh, well, this thing is serious.
Well, I mean, yes, of course. I mean, people do die, and I'm not trivializing that. But if you're looking at the number of deaths against the numbers that are getting well, I think sometimes we don't highlight the recoveries. Because if you look at us as a country, more than, I think 55 or more percent are actually recovering. So really, it really is not that, it is a serious epidemic, but the mortality rate is not that high. And also, the second part is that when you have the infection, unless you've got comorbidities, the main message is make sure that you isolate yourself. And also, let's not forget, the virus does not jump onto us. We transmit it. So actually, you have got the power as an individual to protect yourself. When we say wear a mask, when we say wash your hands every other, all the time, when we say keep the distance, the keeping the distance bit is very important, because remember, this is droplet infection, so it can't travel that far. It then lands on surfaces. When you've touched surfaces, sanitize so that you protect yourself. So really, if people can stick to those, this is what we now call the non-pharmaceutical, interventions. Stick to that, and just make sure that we do what we're told to do. It's still locked down. Stay at home.
Well, in most places now, people are behaving as if it's level 1, and with the introduction of the mind-altering beverages, things are becoming a bit difficult to manage.
Actually, I think, thanks for mentioning that. I think what people are failing to realize about liquor specifically is that, what we're facing now, and I mean, this. So now we're seeing that the results of liquor, whether it's drunken driving or drunken behavior, which then manifests in hospitals. And we can see this in casualties. The casualties are much busy now that, we've opened, we've unbanned liquor. And what that is doing is that the needed health skills and resources for COVID have got to be divided now for casualties. And that really is the issue. It's not like we don't want people to drink, but it's just that they don't act responsibly when they are drunk.
It's not like you want to convert all of us to Bazalwane.
No, not at all. I mean, and anyway, always the issue with liquor is getting drunk, you know? And that is the issue. And obviously, because once then you are under the influence, obviously it means you are no longer in control. Something else is, has got more influence over you. And I think that is the issue. And at the end of the day, you're finding that now people are back to, stab hearts and whatever injuries that we're seeing, which we're not seeing when we're, during the lockdown. Maybe we should go back and ban it. I'll be the first one.
That's what the Gauteng Premier is considering. That they are going to be looking at the numbers. Gauteng seems to be coming up after a bit of a lull, and they think part of it could be, the unbanning. Now, but I want to go back in our closing, because remember I said I want young people who are watching this to also, feel inspired by the work that you have done. So I'm going back to your research for PhD. Right. Your PhD research. I'm just trying to get my papers here now, but it was basically around looking at a relationship between sexually transmitted infections, the inflammation they cause in the genital areas of women, and how that makes them to actually be vulnerable to infections and for the infections to spread faster. But you are the one who did the study. What was the study about, and why did you choose it?
Okay, so when I did my PhD, it was when I was the head of micro at UKZN, and I must say, young people must not hear me saying this. But, if anybody had asked me a few years before then whether I would do a PhD, I would have said no. And I used to say, for a local girl from Pazia, I think I've achieved enough. I don't want to actually do anything more. But here I was, at UKZN, and it was at that time where UKZN was insisting on PhDs for people, for heads. Especially for heads of departments. And so it was after my stint, my long working time at Caprisa. And we had done the work. So when I was at Caprisa, we actually were trying to understand HIV subtype C in the country. So I had set up a cohort of HIV uninfected women who were at high risk, and we followed them up for 24 months. And anybody who unfortunately so study, and we actually followed those women very closely. In that, I think in the first week of infection, till it was like a 6-monthly follow-up. So we were trying to understand what actually happens to the body when it experiences the virus for the first time. What are the immunological factors? And also to look at the virus do when it gets into the body, because there wasn't much data on subtype C.
And
so
you
that was a
that
big
most
study.
of the data was coming from the I'm saying you mentioned
where
that,
it was subtype B.
That work had never been done in Africa.
No, it had not. So because we had that cohort then, we then would do STI, screening, because sexually transmitted infections, mustn't forget HIV is sexually transmitted. So we would actually screen for STIs I can't remember, that's every 6 months or every 3 months, I can't remember. But because remember, the country is actually treating STIs syndromically. If you've got a vaginal discharge, you get this treatment. If you've got an ulcer, you get this treatment. So we then wanted to look to see, what about laboratory diagnosis of STIs? And what my study showed was that, especially for women, if like we're doing now, we're using vaginal discharge, and we say
Yeah.
you've got, an STI. But what we showed was that there's a significant number. In fact, more than 60% of women are actually asymptomatic,
Yes.
which means we are therefore not treating them for STIs because they're asymptomatic. And moreover, not just that, even those that present with a vaginal discharge, the majority of them have got no STIs. It's just a physiological discharge.
Yeah.
So there is over treatment and there's gross under treatment because we are not. And now, so basically, one of the papers that that I published was trying to say we need to look beyond syndromic management, especially for vaginal discharges, because we know that STIs cause an inflammatory process. And in fact, we saw this inflammation whether you were symptomatic or asymptomatic, which means if we want to then manage STIs, we've got to test. We use a laboratory diagnosis. I'm still fighting that battle. We haven't won yet.
Yes.
So I'm still really motivating that we do need to have laboratory-based tests for STIs. So we can manage
There's something that, I was surprised about, that you found that more than half of the people who were infected with this subtype C of HIV, they progressed to below 350, CD4 counts within 2 years. Like 2 years. What used to be called the AIDS stage.
Exactly.
From day of infection to when their immune system is collapsing. 2 years.
Yeah. In fact, what we showed there was that because we could, to an extent, identify when they were infected, follow them over time, and obviously we're monitoring their CD4 counts.
Yeah.
And you remember when you get infected with HIV for the first time, there's a dip in your CD4 count. And then every graph, I can always remember there was a dip and then to come back, go back to above. But we found that in the cohort that we were following, that dip, they never really got back to higher CD4 counts. So you would find that at infection, they would lose more than 50% of their CD4 counts and never got to regain those. So they will live, which means they would start off and continue with lower CD4 counts. And as a result, a significant number of them had, CD4.
Yeah.
Yes.
Yeah. Okay. And then you came up with some algorithm that, as part of, I would say, the stuff that will be your legacy. Yeah. Some algorithm of how these things must be managed going forward. Has that been put in place?
Well, the test and treat came. So now, where you identify somebody, you test them, they are positive, you treat them. So now, irrespective of the CD4 counts, which is really just the best way of managing HIV. And that's why now HIV is no longer a big, it's a chronic illness, like any other chronic illness. So I think, a lot of work really has been done in that area.
All right. And in the lab, in the pathology lab space, or pathologist space, how big is the representation of women? Because I hear you big on women's health issues, and I'm sure you want more women to also follow in your path. How are things there? Is there transformation?
Actually, in pathology, if you look at the numbers, I was head of medical micro, and we had 11 microbiologists, and there was only one male.
Yeah.
All were female. Yeah. So and that it's about that. Actually, at times.
It's not because of the reason that you gave earlier that you wanted good working hours, no calls, so that kids have got somebody to help them with homework.
No, definitely. Yeah, no, there must be that. But I must always say as well, at the same time, it is not easy. Actually, it's not easy disciplines. And a lot of times people come thinking, oh, it's easy, no calls, but then they realize that there's a lot of work that goes with it. But otherwise, so insofar as women are concerned, they're actually overrepresented.
Okay.
Transformation, we still have got a long way to go.
Yeah.
For registrars, maybe, because now I can actually look at it, at national level. Registrars, we're doing relatively okay. But on the qualified
So registrars are the specialists in training for people who don't
specialists in
understand.
training, yeah. The ones that are specializing to become pathologists, whichever discipline. But you find that on the pathologist side, the ones that are already qualified, there we've got a problem in that we are not transformed. We are not as transformed. We don't represent the demographics of the country. And that's one of my other responsibilities. So, yeah. So we have to see. I've been in the post now for 2 years. So I keep saying, I still have got a while. So and remember, I mean, pathologists, the training is 4 years. So we can only change as new pathologists qualify. So it's going to take a while, but there's definite plans and systems in place.
All right. Professor Mlisana, near Makwede, my home girl, because I come from Tabas, which is 10 kilometers
remember,
away.
your dad taught me standard 5 and 6.
Yes, and I must tell people this story that you were in the same class with my elder brother, Uputsazi Nyati, and you guys were so bright that you had to jump a class.
I know. And then I refused. I did not accept that offer.
You didn't accept it?
No, I went to Clarkbury.
Oh.
Yes, because otherwise, if I had gone to a Jumba, I think it was Jumba then, but then I went to do my Form 1 in Clarkbury. Yes, back in the day.
Now I remember you from there. But anyway, thank you very much for making time. I know I asked you at short notice, but you were kind enough to put this hour and a few minutes, to just share with the nation, your understanding of how things are happening, but also to just share a little bit about your journey. So it was not just purely an interview about your role in the pandemic, but to me, it was also a way, just a profiling of somebody who has made a great impact, in the medical field. And for that, I want to thank you. And also to Uputzolile, as the power behind you. You mentioned when you got your PhD in 2015 that he was one of the support pillars of yours. So thank you to him as well and the kids. And is there anything else that you want to say? Otherwise, I'm going to have to say goodbye to my guys.
No, thank you so much. Thank you so much, Fundi. Thank you very much, Dr. Fundi, for this great opportunity. And I must say, I have enjoyed it as well. And one just hopes that, people have picked one or two things. My last, parting shot, I always say this to youngsters, that one thing for me is if you do anything and you do it excellently, it will open doors for you. Nothing beats excellence. So if you're out there, whatever it is that you're doing, always make sure you give it your best shot and you will never regret. Thank you very much.
Thank you, Prof. And thank you, Mkaya. It's a pity I didn't know it's Tugosako, but
Mama,
but anyway. All right, thank you very much.
All right then.
All right, thank you to our viewers. I know we went a little bit over time, but I hope you enjoyed the interaction between myself and Professor Lisana. I now know a little bit more of what the challenges are with the testing in this country, and I am much more positive that things will be better, as we move forward. So I thank you, and may you have a good night.
Thank you.